everyone, and welcome to Your Health, Your Choice. I am Dr. Roopnarine. On tonight's program, we will be discussing some recent research and innovation in the field of diabetes care. In studio with me tonight is Dr. Joseph L. Youssef. Dr. L. Youssef is a clinical endocrinologist and clinical researcher at the Oregon Health and Science University based in the United States of America. Tonight's program has been pre-recorded due to logistical reasons, and therefore we ask that you can send in your questions via our Facebook page tonight, and Dr. El Youssef will do his very best to answer each and every one of your questions. So guys, let's get the show going. Let's talk all about the recent research and innovation in diabetes care, and let's say hello to Dr. Joseph L. Youssef. Dr. El Youssef, great to meet you again. Great to have you in the studio. Welcome to Your Health, Your Choice.
Thank you very much, Robin.
So, Joseph, if you could just tell our viewers, let's give us a little bit of introduction and explanation into the research that you're doing at the moment in diabetes care.
Absolutely. I am based at Oregon Health and Science University in Portland, Oregon, and I work with the Oregon Artificial Pancreas group. So my research is based mostly in adults with type 1 diabetes who are eligible for using an artificial pancreas system.
Right.
The artificial pancreas itself is not really a biological organ that's going to be transplanted into a person. Really, it's just a smart insulin pump that's connected to a glucose sensor, and the two of them talk to each other, allowing the pump to deliver insulin to the person on a strategic delivery program.
Right. So
therefore, the system is programmed to help maintain that person's blood sugar at a very specific level.
All right. So that's a external insulin pump with a glucose sensor to monitor the person's sugar at any point in time, and therefore respond instantaneously with insulin being introduced into the patient's body. Is this new technology? Is this new work, or has this been around for a while?
The work on the artificial pancreas goes back almost to the couple of years or just a few decades after insulin was first discovered. People wanted to find a way to help provide insulin to people that need insulin in an automated fashion. So it's been going on for a long time, but it's really only thanks to the efforts of the Juvenile Diabetes Research Foundation in the US, the JDRF, that we've had a significant uptick in the rate of research and collaboration between many different groups around the world since about 2005, 2006. And artificial pancreas technology has now been available commercially since about 2017.
All right. So is it, Youssef, that you'd have loads of patients with the artificial pancreas at the moment in the United States?
Absolutely, yeah, we do. I mean, we would like to have much more. There's a significant discrepancy between the total number of people that have, or total number of adults that have type 1 diabetes and those that are actually using even just a pump or a sensor, much less an artificial pancreas. But in my clinic, a very large percentage of patients are already on artificial pancreas technology, and I help them out.
All right, so I just want to bring it real back to yourself as well as a researcher. Yes, you tell us about the technology, there's the insulin pump, but what is it exactly that you are researching? What is it that you are studying?
Yeah, so my initial research, which I started back in around 2009, 2010 at OHSU, is based on developing the algorithm that works within the pump, developing the computer system that is receiving the information from the glucose sensor and performing the multiple calculations that will allow the pump to know how much insulin to deliver.
Okay. So it's basically a sort of improving the accuracy and the efficiency of the system.
Yes, actually that's a very good way of describing it, because what we do inside these systems is we use fairly sophisticated mathematics to develop a model of how insulin works in a person's body, and we use that those calculations, that mathematics, to help us predict how much insulin a person might require.
All right. Now, why is this important improvement in diabetes care? For example, traditionally in Trinidad and Tobago, we use a lot of insulins, or we use a lot of medication, tablets, right? But why is this research that you're conducting in the US, why is it game changing for diabetics?
Yeah.
Is it going to change the game?
Yeah. For people living with diabetes, there's often a stigma that goes along with using insulin, that you as a person have done something wrong. You didn't eat right, you didn't exercise properly, you did this to yourself. And there's a big part of getting away from that stigma is providing a system for patients that they can kind of use under the clothing. They don't have to take injections of insulin so other people will see them taking injections. That's one small but still very important
especially
aspect
with teenagers
of it.
and young men and so on, right?
Exactly.
I would agree with that.
But much more importantly, individuals with type 1 diabetes are insulin dependent. They can't survive without insulin. They must use insulin. And a lot of times, it's younger individuals who are very sensitive to insulin. So the total dose that they use is very small. For a person who has type 2 diabetes, the difference in a dose of just a single unit of insulin most likely will mean nothing. It won't make a big change. But a person who has type 1 diabetes and is sensitive to insulin, small changes in the doses mean big changes in their blood sugars. And that's where the system comes into play to help out.
So you're basically, your work helps you, your work is elucidating, right, or understanding how insulin works in the body better. When you'll have peaks and troughs, and using that natural innate hormonal happenings in the human body to replicate that via the machine.
Not necessarily. The way I like to explain it is that what's happening inside the body is like a black box. We can't really see all of the hormonal changes that take place. We don't know all of the myriad factors that could affect somebody's blood sugar, sleep, exercise, hormone, food, all these different things. What we do have is what we are putting into the person's body, the insulin. And what we have coming out is the glucose level. So we use those two signals. Exactly. We use those two signals. The glucose signal itself already has incorporated into it all of the effects of all those things I mentioned before. So we don't need to know all of those things to help make those adjustments if we can get that signal.
I could see this being more very rewarding for pediatric population.
Absolutely.
Can you tell us about that?
Yeah, I don't work specifically with pediatrics. I work mostly with adults with type 1.
Because it's difficult sometimes in the clinical setting to manage pediatric patients. Pediatric diabetic patients. The few that, I mean, I might not be directly involved in the care, but the pediatrician will be in their care, involved in their care. And sometimes they talk to the parents, you know, it's sometimes they keep going back and forth to the hospital. It's a lot of work until they sort of get into a routine or a sort of normal sort of level and know where the playing field is. So I could see something like this being very beneficial to the pediatric population. Has it changed pediatric diabetes in Oregon?
Absolutely. And like we mentioned before, a big part of using these systems is to help people who are very sensitive to insulin. That exactly describes the pediatric population.
And could you describe, is it like a machine that you have to wear with them? Or?
Correct. It's currently there are different forms of the artificial pancreas available. The one that I'm most familiar with, it looks like a pager. It just sits right on your belt. And there's a tubing that comes out delivering insulin underneath the skin at the insertion site. And then another part of the body, there is a glucose sensor that's transmitting wirelessly information to the pump.
So an insulin pump is not necessarily new technology.
No.
I mean, from way back when, we sometimes see patients come in, they have an insulin pump.
Since the 70s and 80s, we've had those.
But what you're saying is that your improvements on it, that's what you're working on, and improving the system itself.
Correct. I would say that over time, as each decade has passed, the ability for us to minimize like microchip technology, allow these pumps to get smaller and smaller, more carryable, and also allowing us to transplant our own algorithms into a pump.
That
has allowed us to really get in and start making some, very significant
treatment as well.
You can individualize treatment. There are a couple of groups around the world right now that are working on artificial pancreas systems that can be individualized to the specific patient.
So, Joseph, I just want to move you a little bit away from your exact research, right? Because you understand a bit of it there. But you're saying it's an artificial pancreatic system, right? But what about organ transplant?
That's a very good question.
I mean, cadavers, people, I mean, transplant, we have kidney transplant that happen.
Correct.
Why is it not possible to have a pancreas transplant?
It is very possible to have a pancreatic transplant, and we actually do those at OHSU as well.
Right.
Individual pancreatic and individual kidney transplants generally don't tend to do as well as the combined kidney and pancreas transplant, which is one of the most common transplants that are done in people with type 1 diabetes. Specifically, we wait, it's an unfortunate situation, but we kind of have to wait until people develop kidney failure and then consider them for both a simultaneous kidney and pancreas transplant. But the pancreatic transplants are viable, and they do help, and they actually improve a person's requirement for insulin. They suffer all of the same potential risks and complications as any other type of organ transplant.
All right. So pancreatic transplants are a viable option as well?
Absolutely, yes.
In your center that you work in the US, how many pancreatic transplants or kidney transplants are done a year?
At our university, it's not a lot. I'm not sure of the exact number. I won't be able to tell you that. But our transplant service is a little bit smaller than, say, those at Mass Gen or the larger universities.
All right. So if we're talking about the future of diabetes, right? How close or how far are we as a scientific community from creating an organ in a lab and putting it into a human?
We are not that far at all, because there are several labs around the United States, around the world actually, that are already reporting on synthetic organs that are being completely synthesized from a very minimal nucleus of tissue, but generating tissue around it using the pluripotency of stem cells in order to create that tissue, and maintaining the viability of the tissue within the lab until it's ready for transplantation. But to jump from that point to the point of actually having a full multi-dimensional organ like a pancreas, for example, I'd say we're still very far away from that.
Okay. Synthetically,
at least.
Okay. About replacement from animals and so on, from other sources.
So replacement of organs from animals would probably not be viable at all, but we do have in our history of insulin using bovine and canine sources of insulin, but we don't do that anymore. Mostly now we're able to synthesize human insulin.
We're able to synthesize. How far are we from a cure for diabetes?
Very good question. And it brings up a number of different points. I would answer that hesitantly by saying, no, we can't really cure diabetes. But as was mentioned in a previous episode of your show, bariatric surgery brings us to the closest point of actually getting to that cure for type 2 diabetes. But the American Diabetes Association is hesitant to use the word cure. They prefer to use the word remission. So we actually have a way of remitting diabetes through bariatric surgery, which has surprised everyone in the metabolic community over the last, say, 10 to 15 years.
Why does bariatric surgery come closest to a cure?
Because bariatric surgery has been proven in the medical literature to be the only way that you can significantly reverse very, very long-standing insulin resistance in people who have both type 2 diabetes and obesity, especially obesity above a BMI of 35. So we're still not fully sure why, but the surgery itself creates some sort of manipulation of the endocrine system within the gut and, of course, into the brain.
But Joseph, that might be more applicable to heavier patients.
It is.
But are we close to, is that really applicable to a type 1, the average type 1 patient who might not be overweight?
Not the average type 1, but in my specific clinic where I deal a lot with adults with type 1 diabetes, we actually can see an overlap between a type 1, type 2 picture where as they age, they develop insulin resistance, become obese. And in those situations, we still can allow bariatric surgery to be of help. The type 1 picture cannot be cured in a sense, but the insulin resistance, that metabolic syndrome component, is significantly affected by bariatric surgery.
Because you reduce the mass.
you reduce their mass, but you also manipulate the gut. You're actually cutting into either the stomach or the small intestine in order to change the passage of food. And for some reason, that alters the endocrine pathways.
Okay. Are we close to curing type 1 diabetes?
Again, I would say hesitantly, no. We do have a lot of research going on for type 1 diabetes, looking at early stages, trying to figure out where the triggers might be that start that autoimmune process that leads to type 1 diabetes.
Is there a role for stem cell research in diabetes?
In general, diabetes research, absolutely, yeah, we definitely. So as we mentioned before, stem cells can be potentially useful for helping to develop, if not a full organ, potentially parts of the organs.
Right.
And there's been a lot of research in developing pancreatic stem cells into islet cells, which can then be transplanted into the person for production of insulin.
All right. Just a more general topic in terms of research. What's the role of what do you see as the role of artificial intelligence in the future of medicine?
Yeah.
They keep saying AI is the wave of the future. We're in the AI generation. Yeah. We haven't really seen it being applied in Trinidad so much in medicine. Yeah. I suspect that it'll initially be applied in radiology more than anything else. Right. What is AI and what's its role in medicine? And what's the advantage to the patients?
I think most people who hear the term artificial intelligence, the first thing that comes to their mind is Terminator, and all the bad things that could potentially happen if a robotic or computerized thing becomes self-aware. But in truth, artificial intelligence is really just the ability.
Turns against man.
Exactly, and turning against man.
Like a sci-fi movie.
Right. But in truth, artificial intelligence is just a way for us as humans to help computerized systems to, in a way, think through multiple different potential scenarios, and in a non-self-aware way learn. They can develop parts of their own system to adjust for new information that's coming in, new scenarios that come in.
Yeah.
So they're not truly self-aware. Artificial intelligence is not about making something that can think for itself, but it can learn based off the specific set of information that comes into it. So in terms of diabetes, for example, a person who is type 1, who has type 1 diabetes and who is using an insulin pump for 5 years, for now an artificial pancreas, we've had these systems since 2017. So for the last 5 years, a person has been using a pump. If that pump is provided an artificial intelligence system, that pump might be able to learn about that person's habits, where they eat, what type of changes in their blood sugars happen for breakfast versus lunch versus dinner, how that might change January versus February versus March, how that might change based on daytime versus nighttime. So all of that information can allow the system to become a lot more personalized to the individual. And we as humans still have to implement all of the safety features to ensure that the system understands you can deliver, up to this maximum of insulin at this point in time. If you go too long without delivering insulin, you have to come back on because the person really needs that drug. So we still have to provide all of the constraints, all of the limits to the system. But within those constraints, the system can manipulate and adjust how it's providing insulin. And that's an example of where artificial intelligence can be really helpful. All
right, Joseph, now is a good time for us to take a little commercial break. And when we come back, we'll push on a little bit more about artificial intelligence, all right?
Okay.
All right, guys, so it's a really interesting discussion tonight. I'm here with Dr. Joseph L. Youssef. He's a clinical researcher based out of Oregon University and Health Sciences in Oregon, United States of America. So this is a pre-recorded show tonight, and we'll invite you to send in your questions during the show on the Facebook feed, and Dr. L. Youssef has agreed to be present on Facebook to answer your questions. All right, guys, we'll see you back in one moment.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're here with Dr. Joseph L. Youssef, clinical researcher at the Oregon Health and Sciences University in Oregon, United States of America. Joseph, just before we went to the break, we were talking about artificial intelligence in medicine. You told us a little example of how you are using artificial intelligence in your work with the insulin pump. Just for the wider field of medicine, is artificial intelligence, and where do you see artificial intelligence being applied in medicine as a field to bring the greatest impact to benefit the patients in Trinidad and Tobago and around the world?
Yeah, so artificial intelligence as a field simply represents our ability to utilize computerized systems in a smarter way.
Correct.
Providing computer algorithms that can learn from information that's coming into it. So that can be applied literally anywhere, and not just in medicine, obviously. It can be applied to almost any other field. In fact, the earliest forms of what would be primordial artificial intelligence would be the systems that we might see in an airplane to help it autopilot, for example. So they have to be able to respond very quickly to differences in air pressure and changes like that. In the medical field specifically, we see a lot of artificial intelligence generally in situations where you might have the patient's life being kind of at risk. And
ICU?
ICU is a very good example.
You need constant monitoring.
You need constant monitoring. You need rapid response to specific situations. And we do see a lot of that in the ICU.
And it could also ease up the manpower resources as well.
Correct, if you have a system that can respond quickly. And it's not really about replacing the manpower, but it is about supplementing the manpower and making it easier for people.
Joseph, if you consider what we just came through the pandemic and all these people dying in ICU all over the world.
Exactly.
And in smaller countries like ours where we have less ICU staff, this could help staff, because it becomes almost like an aid to constant monitoring of a patient in the future.
Absolutely.
I don't know if we're there yet or what, but that's what we predict for the future.
And in fact, the CDC teams in the United States and other global disease monitoring entities can benefit from artificial intelligence in the terms of monitoring disease outbreaks like this. So again, learning from how cases present themselves has allowed the CDC to react a lot quicker, react a lot faster to help in situations like that.
Because the data comes back faster?
Because you get the analysis of the situation faster. If you have a human mind looking at data coming in step by step by step,
it takes longer.
It takes a lot longer for them to pick up on certain trends, to pick up on certain developments in disease outbreaks. And the New York Times, for instance, about a month or two after the lockdown actually began, put out a very nice online article which had an interactive map of how the outbreak started from Wuhan and then spread out past China and around the world. And that's a good example of where monitoring by an artificial intelligence system would have been able to pick up on those things very early on.
It can interpret huge sets of data
very, very rapidly, exactly.
Less human error?
True, less human error, but you probably still have to consider substituting human error for computerized error as well.
But the system needs to learn.
The system has to learn, and the system will be as good as the programmer.
Who's putting it there?
Exactly.
So it won't supersede the human?
No, you'll never, at least at this point in time, you'll never really be able to supersede having a person that understands both, multiple people that understand the multiple different pieces that go into that algorithm.
So the computer is not going to replace the doctor?
No. No. That's a big fear, but not to be realized.
Yeah. Tell us a bit about the current technological trends in terms of glucose monitoring. In Trinidad, traditionally, we still have large, huge amounts of countries around the world, we do the traditional glucose check where you stick the patient and you check it, and then you get a figure, and then the patient might or might not respond to the figure at a given time by giving himself insulin or not, or the recording of these figures. And when they carry it back to the healthcare professional, would lead the healthcare professional to say, well, listen, we need to increase medication or decrease medication,
right,
or change around medication. It still is a rough way, but the best way that we have in medicine so far, I think, where you could elucidate what's on the horizon for treating and monitoring diabetics.
Yeah.
The big deficit that I see is that it's still not real time,
right,
which is what your
right, technology
is allowing. And then it's very dependent on the patient, and it's sometimes it's slow collection of data, and it's tedious sometimes on the patient to be sticking themselves and checking themselves.
No, absolutely.
Tell us about newer technology in glucose checking people's sugars that make it easier on the patient and on the professional. Is there any out there?
Absolutely. There are a lot of new options for us to tap into for monitoring people's blood sugars.
Yeah.
And actually, I'll probably ask to show slide, or the slide that's labeled First Glucose Monitor.
Yeah.
And that's basically just showing a pot.
Right.
And back in the days, we used to have what was called water tasters.
Is that it there?
That is it there, yeah. So this is a 10th or 11th century pot that we used to collect urine in for the doctors at the time. They had to taste in order to tell how sweet the urine was to know if somebody actually had diabetes.
Yeah, intern to test it.
Exactly, you have to get the interns to test that one. And if you go to the second to last slide, which is the technology slide, I just have a listing there of some technologies that we have. And the first set there is the glucose monitoring. So you'll see the glucose urine strips, which is one of the old ways that we used to do this.
Yeah, which GPs traditionally use in the offices and still continue.
Correct. Still helpful in a lot of third world countries because it's very cheap technology and it's a very quick way to help with a diagnosis. But it's not very good for monitoring. You just don't get enough sufficient resolution of data. Exactly.
Quantitative figure.
Correct.
You get a qualitative that you know that someone might be having diabetes.
Exactly.
And you can put it back up there, Josh.
And then the glucose meters is what we were just talking about, the finger stick checks. And glucose meters have come a long way. So the glucose meters that most people might be accustomed to in third world countries would probably be those that don't have Bluetooth technology, that don't have analysis technology already on them. Some of the newest glucose meters are actually really good options for us to use. One Touch, Freestyle, AccuCheck. The newest versions of those models come with Bluetooth connection that can go to your phone, and then your phone can transmit that data securely through a secure network to your provider, and your provider can get that information almost real time. So even the finger sticks right now are still moving forward in terms of technology.
Right.
So Bluetooth connection to the phone will send that information to your doctor, and the doctor will be able to see the data already analyzed, how your blood sugar is doing on a weekly or a bi-weekly basis, where you're going to have the highest blood sugars, where you're having the lowest blood sugars, what percentage of time you're staying within the target range that you're looking for. And just to touch very, very quickly on those points, the American Diabetes Association works hand in hand with a lot of other world groups, WHO and European societies for diabetes, to help develop consensus guidelines on how we use the data for monitoring. So regardless of where the information is coming from, whether we're looking at finger sticks or whether we're looking at a continuous glucose monitor, we still want to make sure that we understand the consensus guidelines. So currently, we have guidelines that suggest how we want people with diagnosis of diabetes to have their blood sugars.
Right.
And in general, we look at the range between 70 milligrams per deciliter as the lowest point, 180 milligrams per deciliter as the highest point, and that range is often referred to as the target range or the in-target range.
Right.
And then the analysis that we do is we determine what percentage of time is that patient spending within that range. What is the time in range? And that's a term that's kind of becoming really hot in diabetes and glucose monitoring right now. What's your time in range? How much time are you spending in range? The target we like to see is 70% or higher. If a person is maintaining 70% or higher time in range, they're actually, if you correlate that with the A1C generally is 7% or lower. And then we look at the time below range, how much time they're spending low, how often they're below 70 or for severe low blood sugars less than 55.
Yeah, adjust immediately.
And then time above range, above that 180 mark.
Right.
And then that brings us to the continuous glucose monitor. That's the next big thing for monitoring blood sugars.
Yeah.
Continuous glucose monitors are devices that are now returning blood sugar values every 5 minutes. So in a single day, you get up to 288 blood sugar values that are traced into a graph.
How does it monitor the glucose? Is it a finger stick or?
No, this is what we call an amperometric device. It's a device that uses a small metallic filament that's implanted underneath the skin. So you put it onto your body, and a small needle injection places that metallic filament that is contiguous with the sensor device outside the body. And around that metallic filament is a coating of an enzyme that reacts with glucose.
Okay.
When that enzyme reacts, you get an electrical impulse that goes along the electrode, and then that gets back to the device. It does a calculation. It assesses what your blood sugar is. It's actually looking at interstitial glucose, the glucose in the fluid underneath the skin, not really the blood glucose. But with all of the information that we've gotten over the past however many, like almost 2 decades now of looking at this type of data, they've been able to put in supplementary algorithms that can help convert the interstitial glucose into what that person's blood sugar actually is.
I can see the huge benefit for type 1 diabetics.
Yeah, but it is just as beneficial for people with type 2 easily. So in this case, we're not looking just at people that use insulin. People that use oral agents or non-insulin injectables or other types of management, even people who don't have diabetes but have a high risk for hypoglycemia,
It could take
can benefit from these devices
and it gives
as
the
well.
person control.
It gives them information, and as a result,
They get
they
control.
say
Empowered.
information is power. Exactly.
Yeah. Which is what we want in medicine.
Yes.
Which is the purpose of education. And now we have the education, which is like the purpose of this program, to give people empowerment through education. But now we have the technology that puts the control and the empowerment back into the person's hand as well.
Absolutely. And training people to use these types of devices is absolutely important. And that also brings in another very important aspect of diabetes management, having your ancillary staff to help you out. The physician is good. The physician can do a lot. The physician cannot do everything.
No.
Having a certified diabetes educator, a person who is trained for nutrition, exercise, and even diabetes technology to help out, to help train our patients to use the devices. It provides the opportunity for additional workforce. So you're providing jobs for individuals that can help out in that role. And it also gives the patient that sense of, hey, these people really pushing to help me understand these things more and have support. Exactly.
That's the big improvements in glucose monitoring, right? That's the greatest technology push. How about insulin delivery? Is there any changes in insulin delivery, any improvements in that?
Yes, there are actually a number of very important updates. Maybe about
Tell our viewers about the updates.
Maybe about delivery. 3 years ago at the American Diabetes Association, I got the chance to go to a closed lecture on oral insulins that are being developed. There's a group in the States that's helping to develop an oral form of insulin. Still purely in research, hasn't been commercialized as yet, and there are obviously a number of issues that they have to work through in terms of dosing and getting past gastric acid digestion and stuff like that. But their initial data was actually looking very promising. So that's one big thing. In terms of insulin delivery that is currently available commercially, we have smart pens. So pens that, again, communicate Bluetooth with your phone and can continuously provide information on how much insulin you're giving, and can actually help that person look at how much insulin is still active in their body. As you know, Robin, when a person gets an injection of insulin underneath the skin, it is extremely different from the pancreas secreting a bolus of insulin. Subcutaneous or under the skin absorption of insulin takes a long time. The first onset of insulin action is 15 to 20 minutes. The peak action is 50 to 70 minutes. And up to 40% of insulin can hang around at up to about 3 to 4 hours afterwards. And this is in what we call rapid acting insulin right now. Whereas from the pancreas, a secretion of insulin happens 8 minutes, 30 minutes peak. By an hour, it's all gone. So
So we're getting technology that will allow easier and continuous monitoring and easier and continuous delivery that is very specific and accurate in terms of your results, which is your blood sugar levels.
Correct. You're able to now.
So we're improving our management of the condition.
Exactly. Now we can supplement our insulin delivery information, which a lot of people don't often think about. They just say, okay, well, my doctor tell me to take this dose and that's what I'm going to do.
Yeah.
But if they actually supplement that information with what their blood sugars are actually doing, there's often a clicking point. It snaps in people's brains where they say, oh, now I can see when I take this insulin here and I take this insulin here and I have this change in my blood sugar. Now I can understand how to manipulate my insulin doses on my own. I can actually know, okay, well, for this particular meal, I'm going to take this amount of insulin, and this is what I expect my blood sugar to be.
So what you're basically saying is that the patient themselves learns.
Exactly.
They learn more about themselves.
Exactly.
They learn more about how their body is working, how the insulin working, how the sugar is learning.
Exactly.
Working. So they, like the computer, begins to learn as well and become smarter.
That's true. And even people who are not very technophilic, people who don't have a lot of understanding of technology and stuff, can still benefit from this because it allows the physician to get information from the patient.
Exactly.
Those smart pens, smart pumps.
Exactly. And the physician could guide them easier as well.
Exactly. All that information will go back to the physician as well.
So, Joseph, we have to take another break.
Sure.
All right. So, guys, we're going to take another break, a short commercial break, and we'll be back to you in one moment.
Connect with ACTN The Voice on Facebook or Instagram at ActnTheVoice.
ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're here with Dr. Joseph L. Youssef, clinical researcher. We're talking about innovation and current research in diabetes care. So, Joseph, we just went through the different glucose monitoring and delivery systems and the technological advances, right? Now, in terms of general diabetes, we expect worldwide that those countries, as they developing countries that are now moving into higher economic status, I suppose you could look towards India and China as two huge populations that are growing in economic value, and also in the Caribbean here as well and Latin America. We expect these countries to develop higher rates of diabetes. As people change their diets, money becomes more affordable, Western lifestyles. What would be your advice if you have to put on a public health hat to countries like these to avoid huge increases in the diabetes rates? What would be your advice to them?
Yeah. First and foremost, we always have to be careful when we are speaking about individual racial groups and the preponderance for diabetes, because a lot of times we might worsen a negative stigma on that group of people. So my information that I have related to, for example, diabetes here in the Caribbean, and research being done here in Trinidad to look at the incidence prevalence of diabetes, suggests to me that there is obviously differences among racial groups, similar to what we might see in the United States as well. In developing countries as a whole, there is a significant association with poor dietary intake, sedentary lifestyle, and the development of diabetes. But in most people's minds, unfortunately, the direction of that association is incorrect. People usually believe that poor diet and exercise, lack of exercise, is what causes diabetes. Specifically, I should say type 2 diabetes. And that's not exactly true. The vast majority of type 2 diabetes is actually genetic. And we
Yes.
know that from concordant studies in twins, right?
Yes.
So in order to change that mindset, we need to make sure that we put that association between diabetes and lifestyle in the right direction.
Yes.
Diabetes first. People do develop diabetes mostly because of genetics.
And people develop diabetes regardless of regardless of lifestyle too. Is that what you're trying to say?
That is correct. In the sense that I have patients who come to my clinic that are Olympic athletes who are on insulin, and they have type 2 diabetes because
of
their genetic preponderance is just so high.
All right. So in Trinidad, we like to say that genetics is basically the finger on the trigger.
Right.
And how you live is whether we pull the trigger or not.
Even in a certain sense, that might still be a little bit too conservative. I will say that genetics really is the finger that pulls the trigger.
Okay.
But the poor lifestyle.
The first thing somebody's going to jump up if you're going to jump up and say, well, what are you talking about? All the bad food
absolutely.
For years, Robin beating me up for eating carbohydrates and eating roti and eating KFC and not exercising and saying that's what caused me to get diabetes. That will lead me to get diabetes and that's what caused diabetes. What do you have to say about the lifestyle? Because I'm sure that we really do heavily emphasize lifestyle interventions in the prevention of diabetes.
And that is the important point. When we look at the intervention point, when do we usually provide that intervention?
Yeah.
The Diabetes Prevention Program, the DPP study, which was one of the largest studies done in the United States looking at type 2 diabetes risk in people that have pre-diabetes.
Yeah.
They looked at lifestyle intervention versus metformin.
Yeah.
And what they showed was that lifestyle intervention allowed a 60% reduction in the progression to type 2 diabetes, while metformin only allowed about a 30 to 40% reduction. So lifestyle intervention is absolutely important. We can never understate that.
Right.
But in a person's mind, the negative connotation, the negative stigma associated with diabetes is because of that association in the layperson's mind that, oh, you got diabetes because you're not eating well, because you're not exercising, and therefore they become, there's a very high...
It's negative.
Exactly.
And falsely negative too.
Falsely negative,
because
I would say.
Because you really can't change too much of your genetic.
Right. But it doesn't mean that the poor diet and the lack of exercise didn't progress the diabetes. That's the important word that we want to use, the progression of diabetes.
Made the event happen earlier.
Present itself much
earlier than it should have.
Exactly.
And as we know, the length of time that someone suffers from diabetes is really very important in terms of the complications of diabetes.
Correct.
So if you're going to get diabetes, we want to push it back to being expressed really much later in life.
Correct. And then if you bring up the fifth to last slide, the one that's labeled, how do we treat it? I like to show this to my students as well.
Wait, Joseph. The question was, what interventions would you do in a public health setting to reduce the huge burden of diabetes? So the point that you were making is that we be focusing too much necessarily on lifestyle.
No, that's not the point I'm making.
What is the point?
Very important. I'm glad you phrased it that way.
We need to recognize genetics.
Absolutely. I think a big part of the public health policy surrounding diabetes is not just the medical management. You remember the WHO definition of health, right?
Yeah.
Physical, mental, and social well-being, and you can add in the spiritual as well, right? But in terms of the mental well-being, diabetes and depression, diabetes and anxiety, diabetes and many other adjustment disorders go hand in hand. And a lot of time, the negative stigma of having diabetes is often why we see those mental health issues alongside it. Not just also because of the negative imagery of obesity, negative imagery of a lot of other metabolic type syndromes. So being sure to let your patients know that a lot of the impact of the genetics in developing diabetes is important, because if you see a 25-year-old person coming into your office with a normal BMI and they have a diagnosis of diabetes, when their family hears that they got diabetes, they're going to think the exact same thing as if a 50-year-old overweight person developed diabetes.
Okay.
It's not going to be separated in their mind that the genetics is really what's pushing that disease to develop.
Okay.
Yeah, but getting back to your point, and getting back hopefully to the slide that I was referencing, how do we treat it? I show this slide to my students because right at the center of it, the core of managing diabetes, you're seeing it there, diet and exercise. Diet
Which is
and
what
exercise.
we know.
Right. So the point is that we don't get away from diet and exercise by reframing how we think about it. It's there. It's always important. And then getting to your point on the public policy and how we're going to implement it to reduce the burden of diabetes, primary health care needs to include this aspect, diet and exercise, as a routine for everyone. Why? Why should we implement healthy eating, healthy lifestyle, exercise for every single individual who comes through our office, regardless of whether they have normal glycemia, pre-diabetes, or diabetes? It's because we still don't have a sure lock way of identifying a person's genetic risk for diabetes. It's the genetics is significantly multiple, right? So therefore, because of the high prevalence of diabetes, because of the high risk of the complications of diabetes, if we then say to ourselves, okay, it's important for us to sort of blanket provide this teaching, this education to people. You can't force people to, you can bring the horse to water, but you can't make it drink. They have to make that choice for themselves. But you provide that education as a generalized point. Diet and exercise is always going to be helpful regardless of where you stand. If you have good genetics and you're not going to get diabetes, the diet and exercise will still help with other potentially genetic diseases, essential hypertension, high cholesterol, other things. If you do have that risk for diabetes and you engage in healthy eating and exercising from an early age, you are minimizing as much as possible your risk for developing diabetes. And later on, if you do develop diabetes, you're reducing your risk for developing the complications of diabetes. So absolutely, we never get away from that diet and exercise talk, but it still is important to make sure that we frame it to our patients properly. I've had the unfortunate discussion with so many of my patients.
Do you feel that doctors sometimes make patients feel embarrassed, ashamed? Is that because I get in that's what you in a very, not I won't say a roundabout way, but in a very intelligent way, you're very much protecting the mental health of your patients when you by the information you've given me back. You're almost shielding them from shaming.
It is important for us to shield them.
Am I
from
reading you
shaming.
right there?
I think that especially for you and I, who are individuals who are trained in a third world country, a lot of times we almost feel like our patient's not going to respond to anything except, the hardcore, exactly, they go for the stick instead of the carrot. But a lot of times that's kind of perpetuating the current way that we manage our patients here anyway. And we want to break away from that. We want to at least give our patients we're seeing for the first time the benefit of the doubt. We give them the explanation. We provide them with the support.
Well, I think Youssef, the key part of it is that positive messages and positive way of framing information and a positive way of treating with people with health problems gives you the better result than being negative and negative imaging.
Exactly.
Right? You cannot, for example, I made this point about a year ago on this program, smokers. For years, people used to smoke. They tell people don't smoke, you're going to cancer. In England, Ireland, all over the world, Asia, put things on negative images on the packages.
Right.
It made no significant dent or reduction in the number of smokers worldwide. People zoom out from the fear. But what made a significant change was the positive imagery. And when the GPs in the community, like myself, went to people and started saying, listen, if you stop smoking, you're going to spend more time with your kids, you're going to be able to play football with your grandkids, you're not going to get heart disease, and therefore you'll feel better, you'll feel stronger, you'll live to be 90 years old. We promise you this will happen, your lungs will repair itself, you have a second chance, stop now.
Yeah, Absolutely. So,
and that made a bigger impact in stopping smoking, rather than these people sticking images up on the packs of cigarettes. You know what I mean?
Exactly.
Positive engagement and positive imagery makes a bigger difference.
And on that point,
is that what you're trying to tell me as well?
Yeah, absolutely. And on that point, if we look at the diet and exercise slide, I have a particular section that is bolded out. On the left side in the middle, I have this statement: to maintain the pleasure of eating by providing non-judgmental messages about food choices. This is actually in the American Diabetes Association standards of care for medical nutrition therapy. This was only added in recently. In the past, this is basically the primary goal.
By providing non-judgmental messages about food.
Nothing about diabetes, nothing about blood sugar control, nothing about
it's like treating people like a responsible individual, not judging them.
Exactly.
Exact words used.
A lot of times when we tell patients the reason why you're coming to see the dietitian is to improve your blood sugars or to get better control of your diabetes or to say that, you know, you want to avoid certain types of foods, all of those things come across as negative messages. And the truth is, everybody likes to eat good foods. There's nobody who doesn't like to eat good foods.
For sure.
So if there's a way that we can maintain the pleasure of eating for an individual and get good blood sugar control, letting the blood sugar control be the secondary objective, that makes so much more sense for us to get success in managing people.
It's an easier way forward.
Exactly, in managing
And a happier
diabetes.
way forward. Joseph, we have about 3 minutes again, right? I'm going to ask you 3 hard fact questions, right? Hard figure questions. What is the target HbA1c levels for your diabetic patients? What should we be aiming for?
So the American Diabetes Association recommends an A1C less than 7% for all patients with diabetes, but we always want to individualize those targets. People who don't have any risk for low blood sugars, the lower you can go, the better.
All right. Blood pressure figures with patients with diabetes. What are the figures?
Again, the recommendation is systolic less than 130, a diastolic less than 80, and you want to individualize for the individual. If they're able to get lower without having any problems from low blood pressure, go lower.
And we were discussing cholesterol levels in patients with diabetes. What would you recommend?
Absolutely. The primary one we usually look at is LDL, which is you're looking at a goal of less than 100 milligrams per deciliter. But if there is previous cardiac manifestations of the disease, cardiac complications, MI, STEMI, that sort of stuff, then you want to go even lower. You want to get down less than 70.
All right, cool. So, Dr. Youssef, we've come to the end of the program. We've run out of time. I would just like to thank you for coming out. I know you're on your vacation. I pulled you away from the beach.
That's all right. That's all right. Always happy to come and talk about that.
I really appreciate it. You give a really refreshing slant to diabetes and to managing patients, and your attitude and positivity. And also the other positive thing of this interview with yourself is that you really highlighted the different technologies available to patients, the benefits to patients, and things that are happening now, which might not really be on stream immediately, but in the coming years. And we look forward to that sort of technology being introduced in Trinidad in the coming years, and it really gives hope. Gives hope to people who have diabetes and to people who might become diabetic in the future, that we are able to accurately manage and treat, and that life will become normal as possible for them, just like anyone else, and not like what happened in the past, or the stigma that was attached to diabetes in the past years, generations before my time, and possibly your time as well. All right, so I'd just like to thank you very much for coming out tonight.
Thank you for having me on, Robin. I appreciate it.
No problem, man. All right, guys, so thank you very much for tuning in tonight. As I said, this program was pre-recorded. We just pulled Dr. Youssef away from his vacation. However, when it's being aired tonight, and you could send in your questions via Facebook feed, and Dr. Youssef will be present in Portland, Oregon, and will be answering it via the Facebook feed. All right, guys, so take care, keep well, God bless, and we'll see you again next week. Take care now, guys. Thanks a lot.